I should say I think we've done a few a few human DX cases. Most of the time we do cases from our setting. So most likely, as Joseph pointed out in the advert today, that the case is probably coming from a place outside Tanzania, and therefore uh, there is some complexity attached to that, because when you are discussing, and maybe I should say, of course, all cases, because medicine is almost the same everywhere, but I think a component of context isn't as prominent when you are not exactly sure where the case is coming from. But regardless, I think today is one of those days where I'm very much excited, because uncertainty is exciting sometimes. So we have a 27 years old female with nausea, vomiting, and then confusion. So here complaints from two different organ systems. So when I hear nausea and vomiting, that takes me to the GIT, and then when I hear confusion, that takes me to the CNS commonly. But then, as you can think about it, if we discuss these two things separately, then I think will take a very long time, because the differentials are very broad for both of these complaints. So what I'll try is as we go through the history, the physical exam, and then labs later, I'll try to see there is a way to connect these two complaints, which are seemingly different or coming from different organ systems. But then quickly you can think about a number of things that can explain both. For example, in no particular order, if someone vomits, has severe vomiting, they lose a lot of fluids, they lose a lot of electrolytes, and both of these separately or in combination can lead to confusion. So if someone is having electrolyte imbalance, particularly hyponatremia, for example, they can have they can present with confusion. But if someone is volume depleted because of severe vomiting, therefore the effective circulating volume is very down, they can present with confusion due to hypoperfusion in the brain. So that's an example. But then another thing is someone can have diabetic ketoacidosis, for example, acidosis in general, that can present with nausea and vomiting and then confusion. So I think we have not had history, but you can also think about infections that can present this way. So for example, if you think about malaria in our setting, we are not sure where this case is coming from, but malaria can present, among other symptoms, you can also have nausea and vomiting, and then you can have confusion from cerebral malaria, for example. So infections, I think, are important to consider in this patient. And then you can also think about many metabolic issues. I believe I've mentioned some of these, like electrolyte imbalance and many others. So let's just hear the history. I think that will help me be more focused.
Sure, that's a nice start. And so let's see the HPI. Starting with nausea and vomiting, this developed 3 weeks ago, and she reports to vomit several times a day. It is associated with loss of appetite, and on some days she only drinks water because of loss of appetite. The vomitus contains the recently eaten food material, and so there is no abdominal pain, no abdominal distension, no constipation or diarrhea. Going to the confusion, this started on the same day of presentation, and her husband reports that she's speaking irrelevant words and answering questions inappropriately. And the confusion is associated with loss of balance when she walks and double vision. But she denies fever, head injury, or shortness of breath. That's HPI.
Okay, so can I see the first slide? Okay, I think although we have had the HPI, I mean, apart from the initial thoughts that I've had, I'll try and see if this extra information can help me make some progress. So we are discussing of nausea and vomiting, which has been there for a while. I think 3 weeks, of course, the classification of symptoms and clinical presentation in general into acute, subacute, and chronic. I think it's arbitrary and sometimes confusing. So for some things, 2 weeks is still considered acute, but then a 3 weeks history. So just to avoid confusion, we could say this is in the subacute territory, but you can also think of it acute to subacute presentation 3 weeks. And then she vomits several times a day. There is loss of appetite. And on some days, she only drinks water. Vomits recently eaten food material, and then there is no abdominal pain, no distension, no constipation, no diarrhea. So the symptoms on the last bullet, I think they are helpful in a way. Not they cannot particularly they cannot make us throw out local causes in the GIT completely, but I think they, at least to some extent, they help us narrow down, or at least make us think that probably local causes in the GIT, maybe they are less likely. But I mean, we could still have nausea and vomiting with local causes in the GIT in absence of abdominal pain, distension, constipation, or diarrhea. But so what I wanted to say for this particular, thinking about nausea and vomiting itself, so there are local and there are systemic causes. So local causes in the GIT, you can think about gastroenteritis, for example. Someone will present with nausea and vomiting. But so when we talk of gastroenteritis, I think a reflex is to think about that this nausea and vomiting will most likely be associated with some sort of abdominal pain, but that is absent in this patient. And then another local cause, apart from inflammatory causes like gastritis, you could think about obstruction. So we have gastric outlet obstruction, for example, which I think for this particular patient, we cannot completely throw it out. But then when you try now to tie the nausea and vomiting with confusion, um, you think a gastric outlet obstruction is probably less likely, but you do not exactly expect abdominal distension. You can have localized distension in the upper part of the abdomen with gastric outlet obstruction, but of course, it will present with vomiting. But then we have not been told about the characteristics or the nature of this vomiting. Is it projectile or non-projectile? But then there is no distension. So when you think about intestinal obstruction, for example, probably not very likely, but it's still possible for someone to have intestinal obstruction and not present with abdominal distension, at least initially. No constipation, no diarrhea. So uh, that's about the local causes in the GIT. And then something else that I pick here is it's associated with loss of appetite. Now, loss of appetite itself, I think it's elusive. We cannot use it. We cannot just use loss of appetite and think about what could be going on, because a lot could be happening. So, for example, if someone has systemic inflammation due to anything, an infection, autoimmune disease, or a malignancy, they can present with loss of appetite. Uh, so you can think of infections. We know malaria, for example, and many other infections, they can present that way. So loss of appetite, uh, should I, of course, I know there are some inflammatory cytokines, like if you talk of interleukin 1-6, which are associated with loss of appetite, but should we use, should we just use the loss of appetite and say most likely this patient is inflamed? I'm not exactly sure at this point. So um, I think for the nausea and vomiting, that's it. Now, can I see the confusion? Okay, so with the confusion, we see that it started on the same day of presentation. Now, I'm not sure if the same day of presentation means 3 weeks ago or when the patient presented to the health facility. I'm not sure about this, but
When the patient presented to the health facility.
okay, so that's 3 weeks after the onset of nausea and vomiting.
Yes.
The patient presents with confusion. And so speaking irrelevant words, answering questions inappropriately, and then loss of balance when she walks, and then there is double vision, but there is no fever, no head injury, no shortness of breath. So with confusion, I should say I have not recognized any particular pattern here, at least to begin with. But one of the mnemonics that I use when I think about altered mental status, because confusion is altered mental status. So I think about IAO tips. And so this is very broad, and I cannot possibly mention everything that goes in there. But so for A, you can think about many things. You can put alcohol in there. So if someone has alcohol intoxication, of course, they can present with altered mental status. So if you think of acidosis as one of the things that I mentioned, and then E, you can think about electrolyte imbalance, you can think about epilepsy. That's for the E or A in Kiswahili. And then for I, again, intoxication. So intoxication with many things. You have opioids, you have benzodiazepines, for example. All these can cause altered mental status in the part of intoxication. And then, or you can think about, again, overdose. And then for you, you think about uremia. So all these things I'm mentioning, I think some of them are a possibility. Some of them are not. Now, so the patient is confused, and then there is a loss of balance when she walks, and there is double vision. So if we think of double vision, for example, now I'm wondering if so for example, if there is something that is going on in the brain, like this patient is having increased intracranial pressure, for example, that one can present with confusion, and then it can also present with nausea and vomiting due to increased intracranial pressure. But these two symptoms are separated in time. So if there is something in the CNS, for example, that means for this particular patient is started, there is increased intracranial pressure. The patient didn't present with confusion earlier on, and then the confusion came later. So that makes me have some reservations. But then local causes in the CNS, like a space occupying lesion, for example, a diffuse process like encephalitis, meningoencephalitis in general, I should say. I think I should entertain that possibility, meningoencephalitis, and then something like intracerebral hemorrhage, which of course can lead to increased intracranial pressure, and then someone can present with vomiting. And then these other symptoms like double vision. And the double vision could be due to a number of things, as cranial nerve palsies, for example. Uh, so all these are a possibility. So I think I've not made much progress, but I'm still trying to tie these two symptoms, the nausea and vomiting, uh, and then the confusion. So I'll see from the other components of history especially chronic illnesses. In this patient diabetic, so she's fairly young, 27 years old, but I need to know if the patient is diabetic, if the patient has any form of immunosuppression, for example, HIV infection, their habits, like if they are taking any recreational drugs, and things like those. I think they will help me make some progress.
Okay, so let's proceed. If your brother system is unremarkable, past medical history, nothing significant, family social history is non-contributory, and she's not on any meds, either prescription meds or like illegal meds. Anything?
Okay, so I mentioned some things that I was eager to hear about, chronic conditions which are not present, not on any medications. So when I was discussing altered mental status, I mentioned the number of medications, and then also recreational drugs. The family histories, the family social histories, and remarkable. So uh, the other components of history were not contributory. They did not help me make any progress. I mean, apart from ruling out some things that I was thinking about if the patient had any chronic illnesses or anything like that. So let's proceed with the physical exam. I'll see if I can make progress from that.
Sure. So, general exam, she's confused. She's a febrile. She's not pale. She's not jaundiced. She has no lower limb edema. Her vital signs are within normal limits. And so the systemic exam, starting the neuro system which is affected. So on higher centers, she's confused. Cranial nerve exam, the left eye is deviated to the left side, but the right eye is normal. Motor exam, her power, deep tendon reflex, plantar reflex are all normal, and she had an ataxic gait. This neuro exam was limited by the fact that she is confused. Other systems, like the respiratory, cardiovascular, per abdomen, were all within normal limits.
Okay, thank you, Joseph. So yes, I think with this physical exam here, it helps me make some progress. So there are some things that I was thinking about. I see some signal coming out of the CNS. So as I said before, I was trying to see or to find a way to connect these two things: nausea and vomiting, and then confusion. So if someone has recently joined, we are discussing. Joseph is presenting a 27 years old female with no significant past medical history, not on any medications, who presented with a 3 weeks history of nausea and vomiting associated with loss of appetite, and a history of confusion on the day of presentation, associated with double vision, and then loss of balance when she walks. But there, I mean, apart from the loss of appetite that I talked about, she did not, a review of systems was unremarkable. The patient did not have any fevers. There were no other GI symptoms like abdominal pain, distension, constipation, or diarrhea. So the general examination seems unremarkable, apart from the fact that she's confused. And then when we come to systemic exam, out of the CNS, we see that the left eye is deviated to the left side, while the right eye is normal. So I mentioned that I would be interested. I mentioned one of the possibilities of the double vision could be that this patient is having some cranial nerve palsies. So the left eye being deviated to the left side, what does that tell me? I think in this slide, maybe there is not too much information to make a lot of conclusions. So I'll just make a few assumptions. our eyes are kept in the primary position. So if I'm looking straight ahead, my eyes will be in the primary position. They are kept in that position by the extraocular muscles, which are supplied by a group of cranial nerves. Cranial nerve number 3, 4, and 6. That is the oculomotor nerve, the trochlear nerve, and then the abducens nerve. So the left eye is deviated to the left side. So that means the lateral rectus muscle is pulling this side to that side. Or that could mean that the medial rectus is weak. And so if the medial rectus is weak, we are probably talking about a third nerve palsy, that is the oculomotor nerve. But then, like I say, that these are assumptions because we've not had some other things like pupillary reaction to light, for example, or the eyelids, whether there is any ptosis or not, because part of those things that I've mentioned are supplied by the oculomotor nerve. But I think that is the assumption that I'll make. If the left eye is deviated to the left side, so that means the lateral rectus is pulling it. Most likely the medial rectus is weak. Uh, and so that means we are probably talking about an oculomotor nerve palsy. So, but then apart from that, motor examination is normal, but the patient has an ataxic gait. So when there is ataxia, ataxia can come from many things, but then some of the common things we talk about sensory ataxia, but okay, maybe sensory exam was limited by the fact that the patient is confused, so we cannot conclude very much about sensory examination in order to see if we are dealing with sensory ataxia or not. But then another thing apart from sensory ataxia is cerebellar ataxia. So if someone is having a lesion in the cerebellum, they can present with ataxia. So those are the common things. There are many other connections that are involved in balance, and therefore if they are affected, uh, you can present with an ataxic gait. But those are the ones that I think I can mention or think of on the fly. So cerebellar ataxia, sensory ataxia, and we do not have other details in order to make conclusions. So, for example, if we are talking of cerebellar ataxia, we would need to hear things like coordination, rapid hand movements, finger nose test, heel shin test, and things like that, which we do not have those details. But then, based on this exam now, it's it's just to make some progress. It's helpful for me to assume that the symptoms that we see are probably explained by something coming out of the CNS. And so what is this thing? Because the patient is confused. Now, if you think of the oculomotor nerve or cranial nerves, we know that the nuclei for most of them are located in the brainstem. But then confusion, if someone is presenting with confusion, that is not a brainstem function. So if you are talking of anything, you're probably talking of something, a diffuse process in the CNS rather than a process that you can say it is localized to a particular part, like for example in the parietal lobes, in the brainstem, in the cerebellum, or any other place. So I think I should consider a diffuse cerebral process that explains this. Um, so, for example, if this patient is having hydrocephalus from any cause, they could present with the confusion and then some cranial nerve pulses. Although more commonly what we see is that when there is increased intracranial pressure, commonly we see is the sixth cranial nerve that is involved because it has a long course. and not the third cranial nerve. But so hydrocephalus, I think I already mentioned a possibility of encephalitis, and then intracerebral hemorrhage. So I think those are the possibilities that we need to consider. But I think I have not made much progress. So let's see, maybe from the investigations, if I can see anything else. But maybe not to forget again that some metabolic issues can also present with something that seems like a diffuse cerebral process, like electrolyte imbalances like hyponatremia or hypernatremia, which I talked about earlier. So all these are possibilities that I should consider.
Sure. So labs, her CBC was normal. Urine analysis, specific gravity of raised at 1.033. The normal is, I think, uh, up to 1.030. And it had ketones 2 plus. Creatinine was normal, B1 was normal, an iron gap elevated 22, bicarb 17, low, ALT elevated 60, AST elevated 44, RBG 5.3 normal, unit toxicology screen was negative, and serum magnesium 1.2 reduced, sodium, potassium, chloride, calcium were within normal limits.
Okay, so with the CBC is normal. The CBC is normal in this patient, and then coming to the urinalysis, elevated specific gravity, and then ketones +2. Also, if the specific gravity, so if we remember our physics, specific gravity is relative density, in other words. So that is the density of whichever thing that you are talking about in comparison to the density of water. So a higher specific gravity, that means that that means the urine that is coming out, contains more solutes than it should. It contains more solutes than it should. So now the thing is it that more solutes are coming out, they are filtered and not reabsorbed, or is it that the concentration or that the urine is more concentrated? I think the latter is a possibility, because this patient is having nausea and vomiting for 3 weeks. So most likely, some mechanisms are coming into place in order to make sure that this patient is not running out of fluid. So that is why the specific gravity is high, because I think the kidneys are working overdrive to make sure that they are retaining fluid. So that means more fluid is reabsorbed, and therefore the fluid that is coming out contains more solutes. That is the explanation that I have for this patient. And then the ketones, of course, if someone is dehydrated, or if someone is not taking in adequately by mouth, they can also present with ketones, because the body is trying to break down fats in order to make sure that the energy requirements are met. So the ketones are probably coming out of fat metabolism, and that's why this patient is having ketonuria. So those are just some of my assumptions. Whether the specific gravity and the ketonuria is giving me some signals which I failed to pick, I'm not exactly sure. I think I can revisit that later. But the creatinine, so that's amazing. The patient has been having uh, vomiting for 3 weeks, no features of acute kidney injury. I think this is good news for the patient. So this patient is having a high anion gap metabolic acidosis. The bicarb is low, anion gap is elevated. So Yes, it would be helpful to think about some causes of high anion gap metabolic acidosis. I think I talked about some things like diabetic ketoacidosis. So we have not, of course, the RBG has not been mentioned so far for this patient, and we know diabetic ketoacidosis could be the first presentation of type 1 diabetes in young patients. This patient is 27, but so a possibility that we are talking about diabetes with diabetic ketoacidosis, I think, cannot be completely thrown out. I do not see a blood glucose being
5.3.
mentioned here.
Yes,
5.3.
yes, it's there below the AST.
Okay. Thank you very much. So I think I overlooked that. Um, so diabetic ketoacidosis is one of the things that can cause a high anion gap metabolic acidosis. But then, so the other things like poisonings. This patient, we have not heard about any recreational drug use, but so there are things like ethylene glycol, uh, methanol, and many other things. So many things that can be taken in either as part of recreational drugs or accidentally sometimes that can lead to a high anion gap metabolic acidosis, because that's what I see here, that the patient has a high anion gap metabolic acidosis. And then there is transaminitis. With elevated ALT and AST, and then something else. So urine toxin screen is negative. So those are things like, for example, ethylene glycol that I was talking about. I know that is not everything that can be picked by a urine toxicology screen. So I think that does not completely throw out the possibility that we are dealing with some sort of toxin. But then could the vomiting itself lead to a high anion gap metabolic acidosis? So the picture that I see here, if someone is vomiting, so when someone vomits, they actually lose acidic fluid because the gastric secretions are concentrated in hydrogen, in hydrochloric acid, and therefore they lose acid. And so when they lose acid, they have to lose the extra base that they have, and therefore there's an increased delivery of bicarbonate in the kidneys. So we would expect if the picture that we are seeing, so someone who is vomiting, basically we expect more of metabolic alkalosis rather than metabolic acidosis. So yes, I think I'm still very much confused with this picture. We see nausea and vomiting. We see that the serum potassium is normal, because if the mechanism that I was talking about with severe vomiting for all these days, we would expect to see some sort of hypokalemia, especially because of the mechanism I explained. You lose hydrogen ions, so you have, in order to try and buffer, the kidneys will try to maintain the acid-base balance by losing more bicarbonate. And by doing so, if you have an increased delivery of negatively charged ions in the distal tubules, you have to maintain the positive charge in the lumen by secreting some cations, and the victim there is potassium. So if the acid base abnormality that we see was coming from the vomiting itself, we would expect to see hypokalemia also. But the sodium, the potassium, the chloride, the calcium are all normal. It's just the magnesium that is low. So we are dealing with high anion gap metabolic acidosis. We are dealing with a picture of transaminitis. I think I've already explained a little bit about the urinalysis that we see. I've made some assumptions. So what exactly is going on in this patient? I think I'm still confused. So do you have any explanation extra labs, any imaging, anything that can help me make some progress.
Yeah, so the UPT was positive, and she did a transvaginal ultrasound, which shows an intrauterine pregnancy at 6.
You are muted, Joseph.
Ooh, yeah, very sorry. Yeah, so the UPT was positive, and she did a transvaginal ultrasound, which showed an intrauterine pregnancy at 6 weeks of gestation, and probably you have to commit for a diagnosis, David.
Okay. With I think before committing to a diagnosis, I should discuss the UPT results. Of course, I think that was an oversight on my side. I should have asked for UPT even before you presented it, because I think it's become cliche that every woman of reproductive age is pregnant until proven otherwise. So I think it would be prudent for me to ask, or to think about whether the patient is pregnant or not, even before you presented that. So uh, the UPT that we see, the UPT that we see being positive, and then an intrauterine pregnancy at 6 weeks, can that explain the patient's presentation? That could be a possibility, that we are dealing with hyperemesis gravidarum. So uh, uh, before committing to a diagnosis, of course, I have to go back from the top down in order to see if I have not missed anything. Uh, but yes, I think hyperemesis gravidarum should be should be one of my differentials. Actually, it should be one among the top differentials that I think about, uh, because this patient is pregnant at 6 weeks, and we see hyperemesis gravidarum during early pregnancy. So this patient has been vomiting because of we know the cause of the nausea and vomiting in pregnant women. It's because of the high levels of human chorionic gonadotrophin. That is what is making them nauseated and vomiting. So that could explain why the patient has been vomiting for 3 weeks non-stop. And then now the vomiting now causing these neurological symptoms, including confusion. I would say um, hypomagnesemia. Hypomagnesemia is not a cation abnormality that I frequently come across. So I think I have read about magnesium. So the things around the things around magnesium, but then the clinical presentation, whether hypomagnesemia can explain the confusion. I think that should be a possibility that I consider, and maybe go back and review my notes on magnesium, especially hypomagnesemia, to see if it can explain the patient's presentation. So I think hyperemesis gravidarum is a possibility that I should think about. Um, but then, uh, some other things. Let me. I'm getting some help today, so let me check the chat here, and this can help me make some progress. So ophthalmoplegia, confusion, and ataxia. Thank you very much, Michael, for pointing this out. So Wernicke's encephalopathy is a thing that we should think about. So thiamine deficiency, and thank you very much. I think if you did not write this in the chat, probably I would not mention it completely. So yes, if someone is presenting with ophthalmoplegia, and then there is confusion and ataxia, Wernicke's encephalopathy is a possibility. Now, Wernicke's encephalopathy, we commonly see it in alcoholics, people who drink a lot of alcohol, and therefore they are malnourished because they are not taking in properly, and therefore they lose they are deficient in thiamine, and so this can lead to the presentation. So for this patient, because she has been vomiting for 3 weeks, so there is hyperemesis gravidarum. I think I should think about it. There is hyperemesis gravidarum, and therefore, because the patient has lost appetite, they are not taking in enough. They are not taking in enough orally. They are at risk of micronutrient deficiencies, especially with vitamins. So all B vitamins are water soluble. Most of them are water soluble, and therefore, with water soluble vitamins, you do not have adequate stores in the body, and therefore you can run short if oral intake is reduced, or if you lose them by any way. So I think when it comes encephalopathy, I should consider it, but more as a complication rather than the primary problem. So I'm thinking this patient has hyperemesis gravidarum and Wernicke's encephalopathy, if at all present, of course, very much supported by the patient's presentation, is a complication. So there's something else here that euglycemic DKA, but then uh, with uh, DKA, so diabetic ketoacidosis, these patients' blood glucoses are normal, and yes, we can have diabetic ketoacidosis without elevated glucose levels, but common presentation is at least the RBG should be something above 14 commonly. So uh, diabetic ketoacidosis, euglycemic DKA, yes, commonly seen with SGLT2 inhibitors. I think around my reading, pregnancy is another thing that is mentioned as a cause of euglycemic DKA. So should we also consider this? I think probably so. Now, the vomiting and the confusion, they could be explained by hyperemesis gravidarum, but then what explains the high anion gap metabolic acidosis? So Roland's theory, I think, does that. If you are dealing with euglycemic DKA, that could explain it. So again, yes. So when it is encephalopathy, that was Michael's thing. So apart from those things in the chart, so something added when it is encephalopathy as a complication, I think, of the hyperemesis gravidarum. Now I'm not exactly sure, because I already explained the pathophysiology. This vomiting, does it explain the high anion gap metabolic acidosis? Based on what I explained, it doesn't seem to be the case. It doesn't seem to be the case. So what is explaining the metabolic acidosis? Should I entertain Roland's hypothesis that we are probably dealing with euglycemic DKA? Possibly. Now, just one final sweep before I commit and sit back and learn what is going on. A 27 years old female presented with 3 weeks history of nausea and vomiting, and then 1 day's history of confusion. On physical examination, so in the history, past medical history, family social review systems unremarkable, apart from loss of appetite and then loss of balance and then double vision, diplopia. And then coming to physical examination, general examination unremarkable apart from confusion. Neurological exam, we see that the left eye is deviated to the left side. So there is ophthalmoplegia. And then the patient has gait ataxia. So that is the problem representation. And then coming to investigations, we see there is transaminitis, and we see a high anion gap metabolic acidosis. We see ketonuria with an elevated specific gravity, and then hypomagnesemia. Other electrolytes completely normal. UPT positive. Yes, so high on the list, hyperemesis gravidarum with Wernicke's encephalopathy. I have not yet found an explanation to the high anion gap metabolic acidosis. But then what could be other possibilities? Local causes in the GIT due to absence of other symptoms, and the discussion that we've already gone through. I think other local causes in the GIT not very likely. But should I consider a possibility of another process going on inside the skull, that is a diffuse cerebral process, or anything else that is going on? So, for example, if so, I mentioned some things like encephalitis, like a space-occupying lesion or hydrocephalus from any cause. So those could explain the confusion, could explain the nausea and vomiting, but then I do not see them explaining the acid-base abnormalities and other lab abnormalities that we've seen. We know someone with an intracerebral process can present with the syndrome of inappropriate ADH secretion. So could that be a possibility for this patient? Because what does the antidiuretic hormone do? So it causes antidiuresis. So is there a process that is going on in the CNS presenting with the syndrome of inappropriate ADH secretion? I'm not exactly sure. So those are the possibilities that I have. Hyperemesis gravidarum with Wernicke's encephalopathy. I think I'll also entertain Roland's possibility of euglycemic DKA based on ketonuria, but then, and the high anion gap metabolic acidosis, but then the RBG is against us. So yeah, that's where I am. Let's now I'll just sit back and listen and learn from this case.
Yeah. So, yeah, very nice discussion, and shout out to those who are commenting here. You guys might be one of the very very good residents that I've never encountered, and David, being a teacher of medicine, would love to have people like you. So that's very nice. Yeah. So before we proceed, much have been solved, but so maybe Michael or whoever in the chat, what do you think about the metabolic? I mean the anion gap metabolic acidosis with the normal RBG. Rand is saying euglycemic DKA. Is there any other thing maybe?
So thank you, Joseph. On my side, I think probably HG itself can explain the high NAN gap. As far as this patient was vomiting for 3 weeks, as far as the summary was given, I was a bit late. But for 3 weeks means also intake was a bit poor. So I will get this patient probably went into starvation. And then later on, the body will shift from glucose metabolism and then start using fat to provide the energy. And then from there, we can produce a lot of ketones. So with these ketones, we can have high anion gap either. So this can cause high anion gap metabolic acidosis. So I was asking for lactate also to see whether another pathway can explain it, but you said it was normal, so I have no any other explanation. But also, I'll keep a differential of euglycemic DKA until proven otherwise, unless we have other investigations to to rule it out by 100%. Thank you.
Yeah, in which year of residence are you, Michael? I've never asked.
Third year, third year.
Third year. Yeah, ready to be a specialist. Very nice. I'm so impressed by you. Uh, when I was in third year, I didn't have that explanation. So that's purely very true. So let's see the teaching points. So this patient was empirically given thiamine at the emergency department, and she had rapid improvement of the symptoms, which proved the diagnosis, which we are all talking about here, being Wernicke's encephalopathy, secondary hyperemesis gravidarum. So yes, what Michael is saying about the anion gap metabolic acidosis is very true. If you see ketoacidosis, there are three causes. Diabetic is one. Two is starvation. This patient not eating 3 weeks now is going into starvation ketoacidosis. And the third is alcoholic ketoacidosis. These people with drinking a lot of alcohol, they replace alcohol with food they don't eat. They also end up with alcoholic ketoacidosis. Uh, euglycemic euglycemic ketoacidosis is a very rare thing, and it gained fame after the introduction of SGLT2 inhibitors. I don't know if you guys read the cases in the NAJM CPC for free. I believe David probably should be giving your residents these things. They should be going and read that series. In this week, they have a case of euglycemic DKA. Very nice case. I read it today. I was so happy. Well elucidated case. So if you go there, you learn more about that. So let's have some teaching points. And David, about the hypomagnesemia. Hypomagnesemia, as you know, it occurs in people who are not eating. Like if you have those the cases you read in theory exams of people with anorexia nervosa. One of the abnormalities of the electrolytes is hypomagnesemia. You're not eating, you get hypomagnesemia. So it goes in the same line. Some teaching points here. So Wernicke's encephalopathy is usually associated with chronic alcoholism. First of all, I saw this case. I solved it in the human DX. I failed it, and so I thought I should bring it here so that we can learn together. But there are other causes of Wernicke's encephalopathy, and this include hyperemesis gravidarum, the topic of today, post-bariatric surgery, very important because people in this country nowadays are going outside, get a bariatric surgery, come back. You can see this. Chronic infections like HIV will make people not to eat, and they end up with hyperemesis Wernicke's encephalopathy, sorry, and malignancies. The pathophysiology is that because of dietary deficiency, uh, thiamine, because of dietary deficiency of thiamine, which leads to anaerobic metabolism, and the lactic acid builds up, which causes cell death. So the cerebral energy utilization of the brain depends much on thiamine-dependent enzymes, and if there's any problem with them, patient will present with encephalopathy. The diagnosis. So the triad of encephalopathy, gait ataxia, and oculomotor dysfunction, which Michael well put, is only seen in one third of cases. So this is just a lucky case we're seeing it, but most of the time you see two of them. Encephalopathy usually present, so plus one of the two is ataxia or oculomotor dysfunction. They don't do serum thiamine because it's unreliable, so it is not usually tested. So you have to have a clinical judgment, and then you see a patient with encephalopathy, you don't know what is happening, you just give thiamine to these patients, because if you give, it won't kill the patient if it's not the disease. But if it's a disease and you're not giving thiamine early on empirically, patient will go to irreversible damage, the Korsakoff. That's why this, if you read, the topic is written Wernicke's Korsakoff syndrome. So Wernicke's is the one early reversible. If it goes into Korsakoff, is irreversible. I've seen several patients with Korsakoff, and you hear the story goes back. This was an alcoholic. Someday this happened, and then they had their Korsakoff. So that's why even in the even in the management of maybe status epilepticus, there is a place where you're told to give thiamine before you give glucose, because you don't know what is happening. Patient just enter in the ED, maybe they're convulsing, you don't know what is happening. So if you push your glucose, you can exacerbate the lactate. I mean the lactate deficiency and the thiamine deficiency, and they will go into Wenitz. Yeah, so this was the case of today. I loved the discussion in the chat. Uh, Michael, very nice. You're one of a kind, Bana. That's very good. David, this is a very good guy. I think one day we should sit back and let Michael discuss these things because he knows a lot. What do you think?
Yes, definitely. And I'm not sure what exactly happened today. I promised last week. I said that this week I needed a co-discussant if I was discussing the case. So I was happy to get co-discussants in the chat because they helped me navigate the complexity of this case and figuring out some things which I wouldn't have thought about. So especially with Wernicke's encephalopathy. So after you presented the UPT results, I was very certain that the vomiting could be explained by hyperemesis gravidarum, but then the neurological symptoms, uh, uh, combining those three things, so confusion, gait ataxia, and then the ophthalmoplegia. So it's something that I've read countless times. But then you see, that's why we we emphasize that medicine is learned by seeing patients, not by reading books, because you can read something, you have a textbook presentation of something, but then putting things together when you see a real life patient is another story. So thank you very much for the case, and thank you very much, Michael and Roland, for the immense help
Mm.
that you gave me today, because without you, I would have overlooked the possibility of Wernicke's encephalopathy. So otherwise, Joseph, this was a very well selected case. I think it taught me a lot because it was very packed. So something starts with nausea, vomiting, and confusion, but then a lot of discussion around acid-base abnormalities, the neurological symptoms that are associated with this. So I think this was an incredible learning experience for me. Thank you very much, and thank you again, Michael and Roland, for the help that you gave me today.
Yeah, maybe final words before we close. This what we present here. This is what physicians do. I know a lot is happening when you learn residence, you do research, you do this, you do that, you present in exams, but you go in a ward and maybe someone comes with confusion and ataxia. This is what you do, this is what you solve. So it doesn't matter how you do in your residency, you have to learn these things because you'll be doing this for the rest of your life. So if Michael, you can do this, still you're a resident. I know residents in this country, they don't teach things like this. That's why me and David decided to do something like this so that we can get a touch that we are learning things that we see in hospitals, and to make us different from everyone else. Everyone else can refill hypertensive medication, but what about cases presenting in the hospital and they're so difficult to solve? So still kudos, Michael. That's very good. Continue on what you're doing, and I hope David will give you the NAGM CPC case series. It's free, very good. Uh, a lot of education in there.
Thank you very much, Joseph. Maybe just to So the I have to repeat again what Joseph said. So residency can be, and medical practice in general, I think in our setting, um, sometimes it can be, it's intense, yes, especially for residency, because you have a number of things that you are doing. So many times actually you can be forced to do superficial reading rather than deep reading. And so with superficial reading, you just ask, for example, what are the common questions that are asked during clinical exams, for example, or for theory exams, maybe solve some past papers and then answer the questions, and then off you go. But with things like these ones, and I think Joseph, I shared with this class actually, as during the first year of residency, uh, during the second semester. So soon after their basic sciences, when they came to the department, I think I talked to the group. Not all of them were present, but I mean, apart from talking to them, I also gave them some resources, including the New England Journal of Medicine CPC cases or medical records of the Massachusetts General Hospital. I told them about the CP solvers, about the capsiders, internal medicine, and the podcasts, all the podcasts that we've been following. So I think it's a reminder for those who have not gone through those resources, to make sure you go back there, because apart from passing exams and earning the degrees, the patients need us, and that's the job of internists, to diagnose difficult patients, because there is a number of patients who are working without diagnosis or with wrong diagnosis, and therefore they have not been relieved of their suffering or symptoms.
Sure.
And these patients are waiting for you. So all the best.
Yeah. Sure.
Yes, and I think for next week maybe after this session I'll reach out to some people. I believe, Joseph, you have a number of cases that we did as we are beginning the platform, the cases that we did just the two of us.
Yeah.
So I think it will be a good starting point to get a discussant maybe next week or anytime soon, to do one case, and then we'll proceed from there. Because as you saw today, a lot of education uh, sits silent in the brains of people who are not qualified to discuss a case. Discusses a case one day, Roland discusses a case, or someone else in the audience. We can learn things that we otherwise couldn't learn, because it's the same discussants almost every time. So maybe for next weekend and the days to come, we expect a breath of fresh air from someone else.
Yeah. Roland, do you have anything?
Roland, see, yes, Roland is having his hand up. Please welcome.
Yes, David. Thank you so much, Dr. David and Joseph, together with Dr. Michael. Indeed, today it was a very beautiful discussion. Just to second on whatever that Michael said, actually, what actually came first also to me, it was Wernicke's encephalopathy. But but then again, when I was trying to brainstorm when you just said about pregnancy, then I had to bring out the thought of euglycemic DKA, though it's a rare case and mostly the one which we do encounter in our ward setups are the one whom they are using SGL2 inhibitors. But when I was reading on the journal in New England Journal of Medicine, then the number one reading course I was surprised to be that it was mostly in pregnant women. So when Joseph just said this woman was pregnant, to second whatever that Michael said, I was like, okay, then I can give maybe a broad discussion to David to also give another thought of school of thought on maybe perhaps what we are dealing is maybe a patient who is euglycemic and in DKA. So this was actually a very beautiful talk, very very brainstorming, and indeed we have learned a lot. I hope on the next phase we are still hoping to learn more on such interesting cases such as this. Thank you so much, David and Joseph, and my brother Michael, for making this discussion a very interesting one. Thank every one of you.
Yeah. Thank you, Roland. I think we are past the hour. We should close. Have a good night, everyone.
Good night.